Androgen insensitivity syndrome, AIS, is a genetic condition where a person with XY chromosomes cannot properly respond to male sex hormones called androgens. Imagine the body's cells as locks that require a specific key, the androgen. In AIS, the lock shape is altered, so the key can't turn, preventing the signal from being received. This results in the body developing along a more female pathway, despite having a male chromosome set. Practical example, a newborn with typical male chromosomes may develop external female characteristics because the hormonal key cannot unlock the cellular response. Explanation: AIS is caused by mutations in the R-androgen receptor gene, located on the X chromosome. These mutations can be inherited from a parent who carries the altered gene, or arise spontaneously during early embryonic development. The mutation is comparable to a typo in a cookbook recipe that changes the final dish. For instance, an inherited missense mutation may replace one amino acid in the receptor protein, rendering it non-functional, while a de novo frameshift mutation can truncate the receptor, eliminating its ability to bind androgen. In AIS, the androgen receptor R is either absent or defective. Even though the testes produce normal or elevated levels of testosterone and dihydrotestosterone, the cells cannot interpret the hormonal signal because the receptor cannot bind or transduce the message. This is like shouting a message, the hormone, into a room where nobody can hear. Consequently, the developmental program follows a default female pathway. Mullerian structures regress, but external genitalia develop without male virilization. Clinically, this explains why individuals with complete AIS have a female phenotype, despite high circulating androgens. AIS is a rare disorder, estimated to affect roughly 1 in 20,000 to 1 in 64,000 newborns assigned male at birth. It occurs across all ethnicities and geographic regions, making it a global but uncommon condition. The rarity can be visualized as a single differently colored marble among thousands in a jar, indicating that while the condition is present worldwide, it represents a small fraction of births. People with complete AIS, CAIS, typically present with external female genitalia, a shallow vaginal pouch, no uterus, and intra-abdominal or inguinal undescended testes. They often have sparse or absent pubic and axillary hair due to androgen resistance, and do not experience normal male secondary sexual development. In partial AIS, PAIS, the phenotype can range from predominantly female with mild virilization to ambiguous genitalia, such as a micropenis or hypospadias. A practical example is a teenage individual raised as female who experiences primary amenorrhea because the uterus is absent. Diagnosis of AIS involves a stepwise approach: clinical assessment of phenotype and family history, hormone assays showing elevated testosterone with a normal or high luteinizing hormone level, imaging to locate undescended testes and confirm absence of Mullerian structures, karyotype analysis demonstrating an XY chromosomal pattern, molecular genetic testing that identifies pathogenic variants in the R gene. This combination of clues is analogous to a detective gathering physical evidence, blood test results, imaging snapshots, and DNA of fingerprints to solve the case. AIS is classified mainly into two forms based on the functional capacity of the androgen receptor. Complete AIS, CAIS, represents a fully non-functional receptor, leading to a completely female external phenotype. Partial AIS, PAIS, indicates a receptor with residual activity, producing a spectrum of genital ambiguity ranging from mildly virilized female genitalia to predominantly male genitalia with varying degrees of hypospadias. The dimmer switch analogy helps visualize the gradient of receptor activity from off, no response, to partially on, some response. Management of AIS focuses on 3 pillars: hormone replacement therapy (HRT), typically estrogen given at puberty to promote breast development, bone health, and secondary female characteristics. Surgical considerations: prophylactic gonadectomy, removal of undescended testes after puberty to eliminate the risk of gonadal malignancy, and optional genital reconstructive surgery for cosmetic or functional reasons. Psychological support: counseling and multidisciplinary care to address gender identity, fertility concerns, and social integration. Regular follow-up visits are essential, akin to routine maintenance for a vehicle, to monitor hormone levels, bone density, and surgical outcomes. Because a IS stems from a germline mutation in the AR gene that occurs before birth, primary prevention is not possible. However, families known to carry a pathogenic AR variant can benefit from genetic counseling before future pregnancies. Carrier testing: prenatal diagnostic options such as chorionic villus sampling or amniocentesis with a R gene analysis, and discussion of reproductive options, including pre-implantation genetic diagnosis, enable informed decision-making and risk assessment for subsequent children. With appropriate estrogen therapy, timely gonadectomy, and psychosocial support, individuals with a IS can lead healthy, active lives with a normal life expectancy. The primary health risk is the development of testicular cancer in undescended testes, which is mitigated by surgical removal after puberty. Bone health should be monitored because estrogen deficiency before HRT can affect peak bone mass. Regular clinical reviews ensure early detection of any complications, supporting a favorable long-term outlook. Cutting-edge research on AIS is exploring several innovative avenues. Gene editing technologies such as CRISPR-Cas9 are being investigated to correct pathogenic AR mutations at the embryonic stage, offering a potential curative approach. Parallel efforts focus on developing selective androgen receptor modulators, SARMs, that might bypass defective receptors or enhance residual activity in partial AIS. Large-scale registries and data-sharing consortia are also gathering phenotypic and genotypic information worldwide to delineate genotype-phenotype correlations, paving the way for personalized therapeutic